Hi, everyone. Welcome. We'll get started in just a moment. We're going to take a moment to let everyone get into the Zoom room. Thank you all for taking the time out of your days to join us. All right, we will go ahead and get started. Welcome to the 2021 STI Treatment Guidelines webinar. It is presented to you by the National Network of STD Clinical Prevention Training Centers. I'm your host, Destiny Kelly, coordinator of the National NNPTC National Coordination Center. If you have technical issues, please use the chat to reach out to our producer, Nexi. This webinar will be recorded and you will have access to the PowerPoint at least 72 hours after the webinar ends. This webinar includes approximately 60 minutes of didactic presentation and approximately 30 minutes of question and answer session. Please hold all your questions until the end of the presentation. And due to the size of this webinar, we will be using the Q&A function on your Zoom toolbar, not the chat box. The NNPTC is made up of 8 regional prevention training centers and 2 national centers. We are CDC funded to train clinicians in the diagnosis, treatment, and prevention of STIs. Our national STD curriculum is currently reviewing and updating all the content to align with the new STI treatment guidelines, and will launch a 2nd edition soon, so please stay tuned. The STD Clinical Consultation Network is a free online system where clinicians can submit complex STI questions and an NNPTC expert will answer in 1 to 5 business days. NACHO and CDC's Division of STD Prevention are collecting information on sexually transmitted disease clinics. NACHO will develop a searchable tool of existing STD clinics and what services they provide. Help us complete the registry by saving the link in the chat and filling it out after the webinar. Continuing education is available through the CDC Training and Education online system. This is a separate system from your registration. Instructions for completing evaluation and obtaining CE will be emailed to the attendees at least 24 hours after the webinar. If you do not see it, please check your spam box. The deadline for completing the evaluation and obtaining CE is October 9th, 2021. Again, you will get that email 24 hours after the webinar has ended. Check your spam box, and the deadline is October 9th, 2021. Today, our goals are to share updates included in the 2021 STI treatment guidelines, discuss the rationale for these updates, and align clinical practice with updates and with the updated guidelines. Our NNPTC expert STI panel is from across the country today, and they include Dr. Nick Van Wagoner from the Southeast PTC, Dr. Karen Wendel from the Denver PTC, Dr. Hilary Reno from the St. Louis PTC, and our Q&A facilitator will be Allison Finkenbinder, who is a women's health nurse practitioner from the Denver PTC. Additionally, Dr. Aaron Trumbull from the CDC will be available during the Q&A session as well. And these are our faculty disclosures. Now I'll turn it over to Dr. Nick Van Wagoner with the Southeast PTC.
Great. Thank you so much, Destiny, for the opportunity to be here, and thank you all for attending. We look forward to sharing the guidelines with you today. Next slide, please. So really the question is why are we here today? And we're here today because we know that STIs continue to have a huge impact in the United States. In fact, STIs have increased for the 6th year in a row. If we look at chlamydia alone, there were 1.8 million cases. That's a 19% increase since 2015. Similarly, gonorrhea and syphilis rates have also increased, and at even higher rates than chlamydia. Finally, and somewhat devastating, we've also seen a huge increase in the case of congenital syphilis, with a 279% increase since 2015. Next slide. So why are we here? Because our patients are suffering not only from physical, but emotional morbidity from these different infections, and in some cases, mortality. We're also here because we know that STIs have a huge cost impact. In fact, $16 billion has been spent or is spent annually on STIs, with $1.1 billion in direct costs on chlamydia, gonorrhea, and syphilis alone. Common and, as we know, preventable infections. Next case, please, or next slide, please. We're also here because we have the opportunity to learn how to better use evidence and the guidelines that have been provided by experts and the CDC to not only prevent, but also treat STIs among vulnerable individuals. So every 5 years, the CDC and national experts come together to review the guidelines and to update them based upon new evidence through review of the literature. This information provides not only the scientific and medical evidence, but it provides us with information in how to best care for our patients and to weigh health outcomes when we are providing that care. A statement from the outline says this: physicians and other healthcare providers have a crucial role in preventing and treating STIs, and these guidelines are intended to assist with this effort. Next slide, please. And so as we move into the specifics of the updates to the STI treatment guidelines, I'd like to give you some highlights as well as themes that you will observe throughout our conversation. The highlight, and the first one is the name change. They are no longer the STD or sexually transmitted diseases treatment guidelines, but the sexually transmitted infections treatment guidelines. There is also further information, more information about screening, in particular among special populations, as Dr. Reno will speak about later on. We also discuss more about 3-site or extragenital screening, more specific screening in syphilis as well as hepatitis C. You will also hear information about updated treatment regimens, specifically on gonorrhea, chlamydia, trichomoniasis, as well as pelvic inflammatory disease. This information will come from Dr. Wendel. There's also more coordination and information and new guidance on prevention, including pre-exposure prophylaxis, post-exposure prophylaxis, as well as expedited partner therapy, specifically in men who have sex with men. You'll also notice some themes as we go through the information. There's an emphasis on antimicrobial stewardship and trying to prevent and address resistance. We'll speak specifically to that as we talk about Neisseria gonorrhea and Mycoplasma genitalium, as well as for a short period or a little bit about Shigella. There's also guidance in treatment that is based upon the pharmacokinetics and pharmacodynamics of the antibiotics that have been selected. And finally, we'll discuss resistance-guided recommendations for the treatment of Mycoplasma genitalium. Next slide, please. And so with that, what I will do is turn it over to Dr. Wendel, who will speak about gonorrhea, chlamydia, and Mycoplasma genitalium and their associated syndromes. Dr. Wendel?
Thanks so much, Nick. Next slide. So the new guidelines contain changes in gonorrhea management, much of which we've already learned about in the December 2020 MMWR. But those changes primarily affect treatment and are driven, as Nick said, by pharmacokinetic and pharmacodynamic data, antimicrobial stewardship considerations, and decreasing azithromycin susceptibility, not only in the gonococcus, but in other STIs. Next slide. So when talking about STIs, our world has gotten broader. We now consider things like Shigella, Campylobacter, and Mycoplasma as part of our world. And we know that there's increasing drug resistance in all of these organisms, and in particularly resistance to macrolides. In addition, we know that macrolides can change the microbiome at the vagina and also in the rectum, and have really had some impact on other community-acquired infections like Streptococcus pneumonia and the ability to use macrolides. And so there's a movement away from dual therapy to monotherapy with ceftriaxone. Next slide. This slide goes over, it's complicated, I know, a lot of the resistance data that we have on gonorrhea. And so you can see the lines represent different antimicrobials and where resistance has gone over the years. And then you can see overlaid sort of CDC guidelines on how to treat gonorrhea. We've been doing dual therapy since 2020, just shifting back now in 2010 and shifting back now in 2020 to monotherapy. But even coming away from ciprofloxacin as a recommended regimen, you can see that the resistance has done nothing but increase, as we've also seen with tetracycline. Thankfully, Syphilis and ceftriaxone remain at the bottom of our graph and relatively stable at less than 1% of resistance. But azithromycin, since the onset of dual therapy, resistance has gone from nearly non-existent to close to 5%. And this certainly was part of the change to that single dose of ceftriaxone. Next slide. Current recommendations for preferred therapy are weight-based, and this is due to that pharmacodynamic and pharmacokinetic data we were talking about, and primarily from a murine model. And so for folks that are less than 150 kilograms, we use 500 milligrams of ceftriaxone, and for those that are greater than 150 kilograms or right at 150, we use a gram. If you can't rule out chlamydia co-infection, for instance, someone you diagnosed by gram stain, then you would go ahead and treat empirically for chlamydia. And in non-pregnant individuals, preferred regimen would be doxycycline 100 twice daily for 7 days. In someone who's pregnant or pregnancy has not been excluded, we would use azithromycin at a gram in a single dose. Next slide. For uncomplicated treatment, we have some alternatives, but they're not to be used for pharyngeal infection because they're just not reliable at that site. So when we're treating genital or rectal infection, we can use gentamicin or azithromycin. This is not something new. These were present in the previous guidelines in 2015. And we use dose of gentamicin at 240 milligrams once or azithromycin at 2 grams, but avoid it in pregnancy. If for patients who decline to have an IM injection, we can use Syphilis at 800 milligrams, and we can also use that for EPT. If chlamydia co-infection not ruled out, as we said, we'd use doxycycline in those that are not pregnant, and for those that are pregnant or not excluded, use that azithromycin single dose. Next slide. When we're doing follow-up for patients with gonorrhea, the new change is that the CDC is recommending we do a test of cure for all pharyngeal infection. And that test of cure can be done anywhere from 7 to 14 days after treatment, and it's to assure that we've cleared that site of infection. Where do those recommendations come from? Well, what we've seen internationally is that treatment failures most commonly emerge at the pharynx, and there are multiple reasons for this, but certainly our drugs don't reach levels at that site that are sufficient many times to clear the infection. In addition, the pharynx is thought to be an area that might have particular capacity to evolve resistance due to other commensals in the area, other Neisseria species, that could exchange antimicrobial resistance factors. We should be telling all of our clients that if their symptoms haven't resolved or substantially improved in 3 to 5 days, they should come in for an assessment for a treatment failure. And we should evaluate them if it's been more than 7 days with a NAT, but whenever possible in a setting of concern for treatment failure to perform a culture and antimicrobial susceptibilities. We want to rescreen everyone with gonorrhea at 3 months with a NAT. Next slide. So in making that consideration for how to do a test of cure at the pharynx, it's important to realize that persistent non-viable organisms can cause a false positive NAT. Reinfection from re-exposure is common, and it can cause also positive results. And therefore, it's important to talk to your client and really understand if they've had a re-exposure to the same partner or new partners. And it's also real important to think about what kind of NAT you're using. So down below, you can see these 2 tables presenting some study results. If you have an RNA NAT, it's likely that by the 2nd week after treatment, so you can see in line 2, there 8 to 14 days, the false positive rate is only 2%. But if you test before 8 days, it might be as high as 8% in the study presented by Hanada and colleagues. However, if you have a DNA test, DNA is much more stable. And so even with dead organisms, you're going to clear RNA before you clear DNA. And if you're doing a DNA-based nucleic acid amplification test, that stuff can stick around for longer and cause you to have a false positive result. So in these results by Besseser and colleagues, you can see at 14 days, there's still an 8% false positive rate. And so pushing out to that outer limit for DNA testing would probably be a good idea for your test of cure for pharyngeal gnats if you're using that DNA-based test. Next slide. Going to move on to chlamydia. Next slide. And the big news here that I think we all saw coming with the December 2020 MMWR is that doxycycline has moved into that favored role. And there are multiple lines of evidence that really informed this. So back in 2015, Geisler and colleagues published in the New England Journal a randomized controlled trial of directly observed therapy of doxycycline azithromycin. And it was really powered to look for non-inferiority. And azithromycin failed to reach that non-inferiority target. But as you can see, the efficacy remained quite good at the urogenital site, with doxycycline 100% effective and azithromycin 97%. But again, this was directly observed. And then a meta-analysis was published by Kong and colleagues in 2015, and this really looked at multiple observational studies. So certainly not as strong an evidence base, but really raised concern about the efficacy of azithromycin at the rectal site for chlamydia infection, and showed that doxycycline was 99.6% effective and azithromycin only 82.9%. This was followed in the last year by reports coming in on 2 randomized controlled trials in men who have sex with men looking at rectal chlamydia and showing superiority of doxycycline over azithromycin with a difference in efficacy of 20 to 26%. Next slide. This really informs the new preferred regimen for doxycycline for chlamydia treatment at all sites at 100 milligrams twice daily for 7 days. And azithromycin moving to that alternate regimen. And in the guidelines, there's a statement to consider evaluation at 4 weeks for rectal chlamydia if you do choose to treat with azithromycin based on drugs tolerability or drug-drug interactions or allergies. Other alternate therapies include levofloxacin. We'll see how that comes up when we're treating epididymitis. Next slide. So many providers have some concerns. There can be obstacles to multi-dose treatment. There can be problems with medication access. Demonstrating this, a retrospective cohort study looking in adolescents in 2 different EDs, and they were evaluated for STIs, given a prescription to fill for STI coverage. In that study, only 58% of those adolescents actually filled the prescription. So certainly having access, having insurance, those can be obstacles. Adherence is known to be an issue with doxycycline regimens of a week, with self-reported adherence being anywhere from 60 to 90% over multiple trials, and medication event monitoring, strict adherence really measured at 16 to 40%. Even with this, we see in many trials that doxy can retain its efficacy, but there are also concerns about confidentiality. And I think we can all imagine our clients that may be adolescents or other patients who may be concerned about partners or parents finding their pill bottle. And so really having those discussions with your clients and using that shared decision-making and balancing both these obstacles and the efficacy data to make the right choice for your client about treatment. Next slide. So now we're going to move on to Mycoplasma genitalium, and this is where the guidelines really expanded and really provide some of that data associating Mycoplasma infection with different STI syndromes. It should be noted that the guidelines really point out that most of this data is coming from observational studies or cross-sectional studies, and that longitudinal data that really helps inform and determine causality is really not very strong at this time for Mycoplasma genitalium. But there's a lot of this cross-sectional data to go over. And so for men, we certainly see that it is not infrequent to see Mycoplasma in men who have NGU, non-chlamydial NGU. And when we're talking about persistent or recurrent NGU, it's highly common. So at 40% of those individuals, and something we should be considering and testing for to help those patients with persistent symptoms for sure. In women, it's been seen in 10 to 30% of cervicitis, up to 22% of women with PID, and there are possible associations with infertility, preterm delivery, spontaneous abortion, and low birth weight. Other associations have been findings of rectal infection, some associations with increased risk for HIV acquisition, and increased HIV shedding in persons who have present Mycoplasma genitalium. Next slide. So what's new in the guidelines is some guidance on how, when to look for M. genitalium. How? Well, good news is we have 2 FDA-approved tests that can be used on genital samples as well as urine gnats. We should be testing, according to the guidelines, for recurrent NGU and cervicitis, persistent epididymitis or proctitis, and we can consider testing in PID. But it's recommended at this time to avoid testing in asymptomatic individuals because the course and of disease and the progression to actual morbidity is unclear. Certainly one of the concerning findings that Nick hinted at is the emergence of drug resistance in Mycoplasma, and it really is concerning for macrolides, with resistance being anywhere from 44 to 90% of isolates in US, Canada, Europe, and Australia, and even reports of fluoroquinolone resistance in the US, but with a very wide range. And so we really need more data here, not knowing if fluoroquinolone resistance is anywhere from 0 to 15%. Next slide. So how should we be treating Mycoplasma? The new guidelines really outline that if we do obtain access to resistance testing, so macrolide resistance testing, and currently it is not available, but when it is available, we would follow that left-hand side of the panel. And you can see here results from Durakan and colleagues looking at the use of 2 arms based on macrolide resistance. And so if there's no resistance, you give 7 days of doxycycline followed by 2.5 grams of azithromycin over 4 days. And with that, you could expect a cure rate as high as 95%. If macrolide resistance is identified, you would go from doxycycline for 7 days to moxifloxacin for 7 days and could expect a cure rate as high as 92%. So at this time, without macrolide resistance testing being available, we are in that regimen where we would give 7 days of doxycycline followed by moxifloxacin for 7 days for uncomplicated disease. If a patient has PID, the recommendation is that we would extend that course to 14 days. And for sex partners, it's recommended that we would do testing. And if Mycoplasma is identified, that they would also receive the same type of treatment. Next slide. So now I want to move on to anogenital syndromes, if you could just back up one. And we're going to talk about a lot of different things. For cervicitis, as you see the picture on the left, the recommendations didn't change significantly. So diagnostic criteria are the same. And the big change, as you might expect, is the switch from using azithromycin if you're empirically treating cervicitis to doxycycline to cover for that chlamydia infection. As was true previously, if you have high rates of gonorrhea in your population, you would also want to use that ceftriaxone weight-based dosing. Next slide. So I'm going to move on to discussion of non-gonococcal urethritis. The guidelines review different etiologic agents, and we see that really less than 50% are caused by chlamydia, 10 to 25% M. genitalium, and 1 to 8% Trichomonas vaginalis, with other organisms being present less frequently, including Haemophilus species, Neisseria meningitis, and adenovirus. But even with all the testing we can pull out, 50%, we're not even going to find a pathogen. It's important to also acknowledge that the guidelines made some changes in diagnostic testing, really creating that breakdown of when we used 2 or more white blood cells per high-powered field from a urethral swab as the diagnostic criteria in high prevalence settings for STIs, and then in lower prevalence settings, really considering using that higher cutoff at 5 white blood cells or more per high-powered field from urethral swabs. Next slide. In all of these cases, we've ruled out or eliminated a high risk for gonococcal disease by using a Gram stain, gentian violet, or methylene blue stains, and not seeing diplococci. And so the preferred regimen is what you might expect for chlamydia, with doxycycline for 7 days and azithromycin falling to that alternate therapy. For persistent or recurrent symptoms, it's recommended, especially in men who have sex with women, that we would check for trichomonas, and in all the other clients that we would also go ahead and test for Mycoplasma genitalium at that time. Next slide. The guidelines for epididymitis review etiologic agents, including STIs and enteric pathogens such as E. coli and Klebsiella, and move away from guiding treatment by age to doing a more thorough risk assessment for enteric pathogens. And so when we're looking at somebody with epididymitis, we want to get really into their sexual practices. It's not just true that a man who has sex with men who has anal insertive sex is at risk for enteric pathogens, but men who are having sex with women who have anal sex are also at risk. So asking about anal sex, asking about issues with urologic abnormalities such as bladder outlet obstruction, BPH, or recent urologic procedures or instrumentation. And finally, people who have systemic diseases like diabetes or immunosuppressing diseases that may place them at higher risk for enteric pathogens. When evaluating these clients, we would use that lower cutoff of the urethral Gram stain at 2 or more white blood cells per high-powered field. Or if we don't have access to that, we can use a first void urine leukocyte esterase or a spun urine at 10 or more white blood cells per high-powered field. It's recommended that we always get gonorrhea and chlamydia nucleic acid amplification testing and always collect that urine for culture and antimicrobial susceptibility. Next slide. When we're treating empirically and we think that a client is only at risk of STIs, we would use the first row coverage, CT and GC suspected pathogens. We would give ceftriaxone, weight-based, and we would extend the course of doxycycline to 10 days. If we consider that a patient might be at risk of STIs and enteric pathogens, we're at row 2, again, weight-based ceftriaxone, followed by levofloxacin. And as I said, that's the alternate regimen for chlamydia, but also gives us that gram-negative enteric coverage. And if we think a client is only at risk for enteric pathogens, treating with a monotherapy with levofloxacin only. But again, we've got that urine in backup to be looking for growth and susceptibilities to guide any changes in therapy. Next slide. PID guidelines had just a few changes. Diagnosis remained the same, evaluation the same with testing for gonorrhea and chlamydia. They do mention that we could consider testing for Mycoplasma, but the big change here for PID is a movement to always recommending that metronidazole use when we're treating for mild to moderate uncomplicated PID. So treating with ceftriaxone, weight-based, as we do for our gonorrhea guidelines, using that doxycycline for 14 days. But instead of saying we can either choose to or choose not to use metronidazole, we would recommend using it every time for that whole 14-day course. And that recommendation is really coming from an ACE study that looked at follow-up at 30 days. And in the clients that were treated with metronidazole as compared to those who were not treated with metronidazole, they saw a reduction in anaerobes, a reduction in mycoplasma, but most importantly, a statistically significant reduction in pelvic tenderness in follow-up. So let's go ahead and add that metronidazole every time to the regimen. New paragraph, or sorry, next slide. In looking at proctitis, etiologic agents, just to review, include gonorrhea, chlamydia, lymphogranuloma venereum, or LGV, herpes simplex, and syphilis. It's important that they really pointed out in the guidelines that we should be doing anoscopy whenever a client is agreeable to do that, because it allows us to see things like ulcerations that really expand our differential and can lead us to empiric therapy. And so diagnostic testing should include rectal testing for gonorrhea and chlamydia, HSV testing. When we're doing that with anoscopy, if we see an ulcer, we'll specifically obtain a swab and send it for HSV PCR from that ulcer, and LGV molecular testing if the NAT is positive. Collect a gram stain and do HIV and syphilis testing with mycoplasma testing for persistent proctitis. Next slide. Empiric therapy is with ceftriaxone and doxycycline for 7 days, with the addition of antivirals such as acyclovir, famciclovir, or valacyclovir if you see ulcerations present. In addition, you would consider doxycycline extension to 21 days if a patient meets criteria for empiric treatment for LGV. The guidelines do note that there are small trials for short course treatment for LGV at 7 days or with azithromycin a gram weekly for 3 weeks, but that the data for this is currently too small to be recommended as a preferred regimen. Next slide. So who should we consider LGV proctitis in? Empirically, patients who present with proctitis with bleeding or ulcerations and a positive rectal NAT, or patients with bleeding and ulcerations who are living with HIV. In those clients, it would be best to empirically extend the course to 21 days, and if possible, grab that LGV PCR. Speaking from our own clinic, obtaining that LGV PCR really allows us to provide accurate follow-up to the client and also engage DIS services, but it often isn't back in time for us to make those decisions about length of therapy. So using those empiric criteria to drive out to 21 days with doxycycline can be important. Next slide. So LGV is certainly a genital ulcer disease that we see intermittently in our clinics, most commonly in proctitis, but more commonly GUD or genital ulcer disease is caused by syphilis and herpes. And so I'm going to turn it over to Nick to cover those two entities. Nick?
Great, thanks so much, Karen. Next slide, please. So as Karen said, the most common genital ulcer diseases that we see in the United States are genital herpes caused by both herpes simplex virus type 2 and herpes simplex virus type 1 and syphilis. Just a brief word about updates in the guidelines about less common causes of genital ulcer disease, specifically with chancroid, again, uncommon in the United States. There is a discussion of non-sexual cutaneous ulcer presentation, typically occurring on the lower extremities. And if we see, especially in a child or an adolescent, only ulcers on the lower extremities and none in the genitalia, we need not be concerned about sexual abuse, whereas if we were to see those in the genitalia, we would be concerned. For granuloma inguinale, again, an uncommon cause. There have been some changes, specifically the removal of ciprofloxacin as an alternative agent for treatment and removal of aminoglycosides as a potential treatment option. Next slide, please. So as we think about genital herpes, the specific changes to this are around our diagnostics. Now, as you know, genital herpes is quite common in the United States, with about 12% of the population, 14 to 49, infected. And there's a range of presentations. When we do see a lesion or something that is concerning for genital herpes, we do want to confirm using virologic tests, because as we have learned through various studies, we're not that great at diagnosing genital herpes clinically. And so the recommendations are for the detection of HSV from genital ulcers or mucocutaneous lesions that we should use HSV PCR. It's now the preferred diagnostic test. Next slide, please. The reason why is because it's much more sensitive and specific than viral culture. It can also distinguish between HSV1 and HSV2. Now, PCR-based HSV tests may not be available everywhere. And so viral culture is still utilized, but it has lower sensitivity, especially for recurrent lesions and basically getting a positive viral culture in that setting, and also for healing lesions. One thing to note, though, is if we are concerned about acyclovir resistance in a patient who is presenting with genital ulcer disease, we do want to use viral culture so that we can detect that resistance. That is the mechanism by which we detect resistance. Next slide, please. There have also been updates on the utilization of serologic tests for the diagnosis of genital herpes or looking for antibodies. So their discussion in the guidelines, they do discuss useful reasons or when serologic tests are useful. For example, recurrent of an atypical genital symptoms or lesions, and in a patient who's had a negative HSV PCR or culture result. It may be that you have a clinical patient who comes in that looks like they have genital herpes, but you are not able to get that clinical confirmation. Certainly early on in infection, if you are suspecting recent acquisition, serologic testing can be helpful to determine, in fact, if that acquisition did occur in the last 2 to 3 months. It can also be useful when we have a patient who has a partner with genital herpes. As well, I've listed indications where screening using serologic tests might be useful in persons at risk and persons living with HIV. But I do want to note that the recommendations are still that we should not perform screening in the general population. Now, when we use serologic testing, the previous guidelines recommended that we do one test and base our diagnosis on one serologic test. The new guidelines now recommend a 2-step serologic testing. The first test, most commonly used in the United States, is an enzyme immunoassay that is based on IgG. We should not use IgM. Again, not a new piece of data, but one that is important to remember that IgG tests are the best. But we do still recognize that there can be false positives, especially in patients with low index values in the most commonly used test known, the herpes select test. And so what we have observed is if we go simply by this first test, we are overdiagnosing genital herpes. We are seeing a lot of false positives. So the recommendation is when we see a positive enzyme immunoassay, we should go ahead and confirm that test with a second test that uses a different antigen. So examples of tests that could be used are the BioKit or a Western blot. Now, if you do not have a second test available to you in your clinic, it is important to share with the patient the limitations of the first test and make them aware of that. Next slide, please. Although we don't have time today to go into all of the details, the guidelines do a really beautiful job of talking about counseling and guidance in patients who have genital herpes, because we know it has a broad range of presentations. And so there's guidance and information provided for the symptomatic patient with genital herpes, for the person who has asymptomatic genital herpes. And because we know the natural history is different for HSV-1 genital herpes with less frequent outbreaks, there is also counseling and guidance provided there. There is also information about HSV hepatitis, which of course is a very rare condition, but a very serious condition. And so to remind you, HSV hepatitis is reported among women who acquire HSV during pregnancy. And we do need to have a high index of suspicion in pregnant women who do present with fever and unexplained severe hepatitis. We should consider HSV in those cases. Next slide, please. One last piece of information that's been updated in the guidelines is some recommendations about prevention of recurrences in persons living with HIV and HSV. Studies have shown that there's an increased risk in persons with these two infections for having increased risk for genital ulcer disease, as well as a worse presentation in the first 6 months after a person starts antiretroviral therapy, and specifically in individuals with low CD4 counts. This worse or more severe and greater likelihood of recurrence is likely part of an immune reconstitution. We also know that antiviral therapies reduce this risk. And so the recommendation is that for individuals who are co-infected, we can place them on suppressive therapy for HSV, and that this should be continued for 6 months after antiretroviral therapy is started, at which point the risk for GUD returns to its baseline levels. Next slide, please. If we now turn our attention to updates to the syphilis guidelines, there is expanded information on the presentation of syphilis. So as we are all taught and all know, the classic presentation of syphilis is a single painless ulcer or chancre at the site of infection. But we do need to be aware that it can present, or that primary syphilis can present as multiple atypical and or painful lesions at the site of infection. And so keep that on your differential, even if you see multiple as well as painful lesions. Next slide, please. There's also further enhanced clinical descriptions of ocular and otic manifestations of syphilis. And I'd like to go through these because we do have to have a high index of suspicion when patients present with eye or ear problems, and definitely we should keep syphilis on the differential. So for ocular syphilis, it can often present as panuveitis, but it can also involve any structure in the anterior or posterior segment of the eye. So it can present as a conjunctivitis, an anterior uveitis, posterior interstitial keratitis, as well as an optic neuritis or a retinal vasculitis. And the importance of paying attention and considering syphilis in our diagnosis is that it can lead to permanent vision loss. And so appropriate testing and care is imperative. For otosyphilis, it typically presents with cochleovestibular symptoms, so things like tinnitus, vertigo, and sensory neuronal hearing loss, which can be unilateral, bilateral. It can be sudden, it can rapidly progress, and it can also result in permanent hearing loss. So again, when we see a patient presenting with these symptoms, we do want to consider syphilis, especially as we gather a sexual history and we identify the possibility that they are vulnerable or have come into contact with that particular organism. Next slide, please. So this isn't really new, and I'm not going to take time to go into the details of the traditional and reverse sequence, but just to make you aware that we do have these two serologic screening algorithms. What I will point out is with the traditional that it is a manual process, and so requires a lot of person power. The reverse sequence has been put in place to allow a portion of the process to be automated, to allow for removal of individuals, screening quickly when we have many, many samples to evaluate, to identify people who are enzyme immunoassay positive, and then look specifically at those individuals for the potential syphilis infection. Again, happy to come back to this in answering questions, but want to make sure we have time to cover all of the new updates. Next slide, please. So there's no new data in these about treatment of syphilis. Specifically, though, I do want to make you aware of a phase 4 comparative trial that's looking at benzathine penicillin G for the treatment of early syphilis in persons with living with and without HIV. And the comparison is 1 versus 3 injections of benzathine penicillin. There is further discussion of alternative regimens for individuals who cannot have penicillin. Ceftriaxone, 1 gram IV times 10 days, was reported in Clinical Infectious Diseases about 3 years ago. So there is some data on that as a potential option, although more data is needed. There is insufficient data, however, on amoxicillin and probenecid as a potential therapy. The guidelines also discuss a topic which is often a challenge to all of us in the world of STIs, and that is looking at serologic responses after treatment of syphilis. As we all know, the goal is to, or what we expect to demonstrate a serologic response is a fourfold reduction in titer. But we do see in certain circumstances that we may not see that, or it may be less likely. In particularly, an inadequate serologic response is associated with lower titers, those less than 1 to 8, in persons of older age and with later stages of syphilis. When should we consider treatment failure? Well, these guidelines recommend that at 12 months after treatment for primary, secondary, and early latent, and 24 months after treatment for late latent or unknown duration. Next slide, please. A few more comments about syphilis and changes to the guidelines, specifically around lumbar punctures. You will be glad to know this, and your patients will be glad to know that in neurosyphilis, no repeat CSF exam at 6 months is required when you see an adequate RPR response. This is specific to our patients who do not have HIV and who have HIV and are on antiretroviral therapy. As well, for isolated ocular symptoms and no cranial nerve dysfunction, we do not need to do CSF examination. And for otic syphilis, CSF examination is not necessary. Next slide, please. So what do we do with penicillin allergies? Well, remember that there are no proven alternatives for neurosyphilis, congenital syphilis, or syphilis in pregnancy. We should note, and as discussed in the guidelines, that there is really some imprecision in the use of allergy to refer among our patients. And so when we're talking with a patient, we definitely want to validate that they truly do have a penicillin allergy. There have also been updates that when it becomes relevant to you in your care, there have been updates to penicillin skin testings for your reference, as well as ceftriaxone and oral challenge, as well as modified desensitization protocols. Next slide. And so with that, I'll conclude the genital ulcer disease section and return it to Karen to talk about vaginitis.
Thanks, Nick. So we're going to talk about 3 different types of vaginitis: trichomonas, bacterial vaginosis, and candida vaginitis. Next slide. So as we all know, bacterial vaginosis represents a dysbiosis, so a decrease in lactobacilli that are producing hydrogen peroxide and lactic acid, and an increase in anaerobes such as Gardnerella, mobiluncus, and Provotella. The CDC new guidelines really outline a lot of the point-of-care tests that are now available and NATs that are available to help us make the BV diagnosis, but it's good to realize that AMSL criteria are still acceptable and work well. And most of these tests are validated using the Nugent test, which is a gram stain characterization of the microbiome from the vagina. Recommended treatments really have not changed. They include the metronidazole orally for 7 days, metrogel for 5 days, or clindamycin 2% intravaginal for 7 days. But what's new in the guidelines this time is a change in the alternate therapy, including single dose regimens for non-pregnant persons, including a new nitroimidazole, signitazole, at 2 grams. This comes as granules, and patients can sprinkle this on unsweetened applesauce or yogurt or pudding and take it as a single dose. Included also is a newer form of metronidazole, 1.3% vaginal gel, and Clindes 2% vaginal cream. Now, with these single dose therapies, they can be more expensive, and information is included in the guidelines about how patients might access assistance programs to access these therapies. There's no data linking nitroimidazoles to alcohol adverse effects. And I think this is something that's news to all of us that have been in the past counseling clients about disulfiram reactions. I encourage you to take a look at this area in the guidelines that really outlines the paucity of data linking metronidazole or other nitroimidazoles with adverse reactions associated with alcohol ingestion. And so it's recommended that we stop telling clients that there is a problem between alcohol and these agents, and that we stop avoiding nitroimidazoles in people who are having issues with alcohol use. Next slide. Trichomonas has several updates. I think the CDC guidelines do a really nice job of outlining some of the newer diagnostics that are available. We can use wet prep, but it has a very low sensitivity, around 50%. We can use antigen-based tests or even some rapid turnaround nucleic acid amplification tests that can be used right there in the clinic if possible in association with the lab. But then we can send it away for lab-based nucleic acid amplification tests as well. It's important to realize if a patient has persistent symptoms that those NAT tests can take up to 3 weeks or more to kind of get rid of all that genetic material and avoid false positives. So we should wait at least 3 weeks prior to reusing those if reassessing a patient. The big news here is that the treatment guidelines for preferred therapy for trichomonas have changed from a single dose of metronidazole and really favor that 500 milligrams twice daily for 7 days. And a single dose of metronidazole has been removed from preferred and alternate therapy. Alternate therapy now is that tinidazole 2-gram oral dose once. And this really came from multiple lines of evidence, including meta-analyses that demonstrated superiority of multi-dose therapy, as well as a randomized controlled trial by Kissinger and colleagues that was published in Lancet Infectious Disease, demonstrating the improvement in treatment failure based on 7 days treatment. So if you look at the graph on the right-hand side, you can see for a culture-based test of cure, single dose treatment was associated with failure in about 15% of times. If you look at NAT or culture performed in test of cure, treatment failure could be as high as 18% for single dose therapy, for multi-dose therapy being closer to 11% for that NAT culture test of cure. In men, the preferred therapy has remained 2 grams orally once of metronidazole, or using that alternate regimen of tinidazole 2 grams orally once. The guidelines continue to have an area that provides guidance for treatment failure and persistent symptoms in using higher doses of nitroimidazoles that metronidazole and tinidazole are part of, that same class. And also taking advantage of getting a culture from the CDC, inserting a vaginal swab into what we call an in-pouch test and sending that back to the CDC for culture and susceptibility testing to help guide therapy if increasing doses of nitroimidazoles fails to clear the infection. Next slide. For vulvovaginal candidiasis, the guidelines outline use of KOH microscopy, which has a lower sensitivity, somewhere around 50%, and then using and favoring culture and PCR in those symptomatic individuals for higher sensitivity in identifying yeast. It should be noted that Candida albicans has had increasing resistance identified in the last several years for azoles, and non-albicans species such as Candida glabrata are intrinsically resistant to azoles and therefore can be associated with treatment failures. The guidelines continue to break down vulvovaginal candidiasis into uncomplicated and complicated forms. And in uncomplicated, we can use the single doses of fluconazole, or we can treat topically with 1 to 3 days. And all these regimens are outlined in the guidelines document. Complicated disease is considered disease that is recurrent, severe, or involves non-albicans species, or vulvovaginitis that's occurring in an immunosuppressed individual, somebody with diabetes or HIV. And those treatment regimens can include fluconazole at 2 to 3 doses, separated by 72 hours, depending on where your client falls in that complicated range. Or it can include extended courses of topical therapy, anywhere from 7 to 14 days. If a patient has recurrent vulvovaginal candidiasis, 3 or more episodes in a year, it's noted that this is a large economic burden in the United States and is not infrequent. And the patient should really be evaluated for secondary causes of disease like diabetes, HIV, other immunocompromising conditions. And one can consider therapy after the initial treatment course with fluconazole weekly for 6 months. Something that's newly discussed in these guidelines is data that's come out linking even a single dose of fluconazole to adverse events in pregnancy with increased risk of congenital anomalies and spontaneous abortion. So really outlining the importance of us identifying the risk of pregnancy in our clients as we're thinking about how we're going to manage vulvovaginal candidiasis in our client. Next slide. So now I'm going to hand it over to Hilary Reno to cover HPV, special populations, sexual assault, and hepatitis. Hilary?
Thanks, Karen. Hi, everyone. We're going to start off with HPV virus. As we all know, it is the most common STI and has quite a significant impact. HPV can cause anogenital warts, and different types of HPV are also causative agents of cervical cancer and linked to other types of cancer like anal cancer and potentially head and neck cancer. Next slide, please. So as I talked about, there's 4 main types of HPV that are targeted in our vaccination science. We have actually a 9-valent vaccine that is available that also targets other types of HPV that are linked to precancerous and cancerous outcomes. The vaccination is a cancer-preventing vaccine, and the 2021 guidelines highlight some of the more current recommendations for vaccination schedule, including that it is approved for those under 46 years old, though of course the ACIP recommendations focus on vaccination for adolescents at 11 or 12 years old with a 2-dose schedule, and then for if they're under 15 when they start the series, and then a 3-dose schedule for those over 15 or if they are immune compromised. Next slide, please. So let's talk about genital warts treatment and the minimum changes seen in the 2021 guidelines. The main treatment recommendations are shown here, and those are unchanged from the 2015 guidelines. There are, however, additional treatment boxes and information about what options in the treatment regimens are specifically indicated potentially for anogenital warts, those largely noted at the urethral meatus, vaginal location, are those that are intraanal. So there's additional information there. It also includes sections about management for people who may be pregnant or have HIV, and those have been updated. Next section. That slide. So HPV screening is a very big focus of the section of the HPV section in the guidelines, and for good reason. Of course, we know that there are, at least in 2019, there were 13,000 cases of cervical cancer in the US, and over 4,000 people died from cervical cancer in 2019. And so in addition to vaccination, we also or have screening at our fingertips to prevent cancer development. So the 2021 guidelines update the screening recommendations in line with other guideline groups. And I'll show you a table that kind of shows all of those broken down. But we know that now the current the guideline groups recommend that for persons with the cervix at average risk, they should start screening at 21 years and continue through 65 years. The spacing of that screening has been recommended to be spaced out, and not every year as has been in the past, but every 3 years for if cytology alone is done for with cytology alone for those in their 20s, and then over 30 every 3 years, unless you combine that with an HPV test that is has been developed since the 2015 guidelines. And then screening can be done every 5 years. The 2021 guidelines do a really nice job of grouping and pulling in all of these recommendations on screening from major groups. Thank you. The next slide. And there is a table that this is just part of table 1 in this section that you can see it contains the USPSTF, ACOG, and ACS screening guidelines. And I actually have not seen this in other modalities. And so this is a great resource for clinicians in determining appropriate screening schedules. Next slide, please. Continuing with screening, there is some additional language around anal cancer screening and management, though there is still much to be learned here. So it is certainly an area where we need more data and understanding, but there is some language that indicates the utility of digital rectal exams that could be useful to detect anal masses in people, especially those with HIV, and possibly cisgender men who have sex with cisgender men without HIV. Now, this comes from the HIV opportunistic infection guidelines and the Internal Anal Neoplasia Society recommendations. Our STI treatment guidelines do note that anal cytology is not recommended for anal cancer screening, and HPV tests are not clinically useful for anal cancer screening with the data that we have now. They do review the data we know about anal cytology and briefly discuss management of anal HCIL, but not in great detail because we need the results from studies that are ongoing and from future studies to help inform additional guidance. Next slide. As far as the hepatitis, those are largely unchanged from 2015, except for a few notable differences. For hepatitis A, the table 3 there that talks about the vaccine regimens has been updated and includes information on the combined hepatitis A and hepatitis B vaccine, as well as the section continues to list the current ACIP recommendations on vaccination. There is also some updated parameters in the post-exposure prophylaxis management of hepatitis A, noting that immune globulin is indicated for those under 6 months, those that are immune compromised, people with liver disease, and people who cannot receive the vaccine. And again, a table accompanies this. Next slide, please. For hepatitis B, there is the continued recommendation that vaccination be offered to people seeking STI care at STI clinics or in other clinical settings. And then the pre-vaccination serologic testing has been updated to include hepatitis B surface antigen, anti-Hep B surface, and total anti-Hep B core antibodies as well. And a reminder that people with hepatitis B infection should be tested for other STIs. And as with the other sections, there is a table summarizing a lot of this information. Next slide. For hepatitis C, there was a big change. In the 2015 guidelines, hepatitis C was noted to be an emerging issue, but it has its own section now. And it includes updated epidemiology, especially in regards to hepatitis C and HIV co-infection, as well as some more information in its transmission its transmission. The CDC updated screening guidelines that all adults over 18 should be screened during their lifetime, that all pregnant people should be screened during each pregnancy for hepatitis C, except where the prevalence is less than 0.1%. And then routine screening is recommended for people with ongoing risk factors. So there is some information and discussion of hepatitis C and pregnancy screening recommendations because of that change. And though treatment is not in the scope of these guidelines, they do contain links to the resources because certainly the treatment landscape for hepatitis C has improved in a wonderful direction since 2015. Next slide. In the section on sexual assault and child abuse, there is some additional information on the exam and testing indicated for cisgender men who have sex with cisgender men survivors of sexual assault, which was a gap in previous treatment guidelines. It does focus on the prophylactic treatment of STIs and updates those to include the doses that are currently indicated for the infections that they're empirically covering. So of course, ceftriaxone was increased to 500 milligrams in the regimen. Next section, please. The next slide, please. There is at the beginning of the guidelines document extensive prevention information and different sections. One of the first discusses the new 5 Ps of taking a sexual history. These 5 Ps have been updated to include gender affirming language. And along with it, there is a link to a guide to taking a sexual history, which is a new toolkit that is updated to be include language that's gender affirming, trauma informed, and patient-centered. There's also some new information out on prevention counseling, and that there has been some studies that have shown success with shorter interventions, as well as some web-based programs. Language has been updated to reflect external and internal condoms and their benefits, and a new section on multi-purpose technologies. For example, the ring that can be inserted into the vagina that would deliver both potentially PrEP medication as well as birth control medication. So there's a new section on that, those exciting developments. And then there is a discussion on the data that as it currently exists when it comes to STI, PrEP, and PEP. Some of you may not have heard about this, but there have been studies that have indicated that people can take doxycycline after unprotected or less protected sex to prevent STIs, and specifically this would apply to chlamydia and syphilis. And there have been indications from PrEP studies that have examined doxycycline as PrEP to prevent the people developing syphilis and chlamydia. So there's a review of the current data, though no hard and firm recommendations exist now, because obviously many more studies are needed to examine the implications of these potential regimens. Next slide, please. There is some information expanded on management of sex partners when it comes to chlamydia or gonorrhea. Obviously, the recommendation still exists that all sex partners should have evaluation, that partners of the patient with the infection in the past 60 days should be presumptively treated, and that expedited partner therapy for use in the management of gonorrhea and chlamydia in heterosexuals is indicated, and that there's new language discussing that we can consider expedited partner therapy with cisgender men who have sex with cisgender men via shared decision making, meaning that though that there could be some benefit there, and that though the studies may not be as extensive as we have seen with the in heterosexuals, that for MSM there could be some benefit. And just a note with trichomonas, expedited partner therapy, the guidelines discuss again, but that there may be situations in which it could be beneficial, but that no studies so far have shown that expedited partner therapy offers benefit over traditional methods of requesting a patient's partners seek care. Additional management of sex partner recommendations include presumptively treating the most recent partner, even if that contact was over 60 days. And then patients should avoid sex until their therapy is completed and the patient and partner are asymptomatic. Next slide, please. So expedited partner therapy, obviously, since our regimens have changed for gonorrhea and chlamydia, the regimens for EPT will change as well. Sulfixim's dose has increased from 400 to 800 milligrams in a one-time dose. And if chlamydia co-infection was present or not excluded, those that were not pregnant would be considered to receive doxycycline 7-day course. If the partner was pregnant or pregnancy couldn't be excluded, then obviously azithromycin would be the preferred regimen. When it comes to chlamydia expedited partner therapy, patients that are not pregnant, doxycycline would be the recommended regimen with azithromycin as an alternative, and one that would be recommended for partners who are pregnant or pregnancy could not be excluded. Next slide, please. So just briefly, in conclusion, we're going to run through the special populations. Each of these populations has a specific section in the guidelines at the beginning to talk about special circumstances. And so we're going to really just highlight the differences, though there's a ton of information here. Next slide, please. So when it comes to pregnancy and syphilis screening, there has been a few changes. The first of which is that serologic screening, depending on the community prevalence of syphilis, as well as other factors for the pregnant person, we would like there to be serologic screening again at 28 weeks and delivery. The 2015 guidelines said third trimester, and what we saw in practice was that this varied quite a bit and was sometimes close enough to delivery to make it impossible to treat syphilis before delivery would have occurred. So if the serologic screening is going to be performed again in pregnancy after that first trimester or first prenatal visit screening, 28 weeks could be a targeted date, because we understand that other testing typically happens at 28 weeks, including glucose tolerance testing. So the goal was to make that convenient both to the patient and the clinician. Maternal risk factors were reviewed and are largely the same as previous recommendations, including some additional information on what we know about the ongoing congenital syphilis cases, to include those that are unhoused or late to prenatal care, especially if after the second trimester or if they have no prenatal care. The risk of infection is really based on ongoing behaviors and partner treatment, and the management can be either with non-treponemal or treponemal screening test. There is some information on how to follow titers, and that a repeat RPR 8 weeks after treatment, unless there were signs of primary or secondary syphilis, and that if there is a reinfection or treatment failure, you would see that 4-time increase in titer after treatment, 2 weeks after treatment. So that is also very important information and indicates the need for continuing clinical follow-up. Next slide, please. And then in the section on adolescents, screening recommendations really remain unchanged, with some additions, including permissive testing for rectal screening in adolescent females based on reported behaviors, and the recommendations for rectal and pharyngeal screening in young MSM. And then this section also includes some additional notes on resources for PrEP in adolescent populations. Next slide, please. For cisgender men who have sex with cisgender men, the importance is really on, and the emphasis is really on the importance of taking a sexual history and providing tailored counseling, testing, and care. The section also includes a continued review of PrEP, as with the other sexual populations, and its application, particularly to MSM. And there is a new section here on PEP and PrEP as well that talks about the data I've already kind of highlighted. There's also a section on enteric organisms too, and how they can also be STIs, things like Giardia and crypto, etc. Next section, please. So lastly, the special population sections include an expanded section on women who have sex with women and women who have sex with women and men, with updated information, of course, in the BV and trichomonas data, and especially in the epidemiologic data for those populations. And there is a much expanded and needed section highlighting aspects of care for transgender and gender diverse people, including a discussion on gender affirming and sexual health principles, as well as some screening recommendations that boil down to following gender-based recommendations based on anatomy. And so this really indicates the need for careful history taking with gender affirming language and trauma-informed care principles, especially in the transgender and gender diverse population. I believe that concludes our summary. Next slide. Yes, so if you have any questions, you have this email that you can, we're going to spend some time on questions now, but there's this email here for you. All right, thank you.
Great. Thank you, Dr. Reno. And I'd just like to also thank Dr. Wendel and Dr. Van Gardner. My name's Allison Finkenbinder, and I'm going to be bringing up some of the questions from the Q&A that came up while you all were speaking. Just want to remind our participants to please submit your questions if you have more into the Q&A box, and you should see that along the lower bar. We do have about 20 minutes to go over questions, and then also take a look in the chat. If we don't get to your question, there is an email address that you can send it to, stitxguidelines@cdc.gov. You can submit your questions there and they will get back to you. They have clinical faculty to help answer those. But let's start. I'd like to start off with a question for Dr. Wendel about chlamydia. The question is, when studies report 100% efficacy for treating urogenital chlamydia with doxycycline, does that only consider strict adherence, or is there some leeway? And I just want to say, I think this wraps into us as providers trying to make a decision with people about the azithromycin versus the doxy, and how do we counsel folks about that?
So I think this is a fabulous question. And I think the data on this doesn't create a very clear delineation of how many doses can be missed. There certainly is some leeway when you look at the studies and the rates of treatment failure that have been reported in these studies that look at adherence. You know, even with very poor reported adherence in some of these studies, the efficacy has remained very high. Similarly, in these randomized controlled trials that we saw coming out on rectal chlamydia, these folks were at home taking it. There may have been, some non-adherence with it. It was randomized placebo controlled, and it still retained very high efficacy. So I can't give you an absolute number. And this comes up all the time. I think in clinic, we have patients call in and say, I missed 2 doses of doxycycline. My assessment from the data is that they're likely to do fine. But where to specifically draw that line is not very clear. And so the guidelines also don't give clear guidance on that. And so I usually encourage folks to repeat that screening at 3 months, and certainly to come in if they have any concerns about re-exposure, and also if they're having any symptoms. I usually say 2 to 3 missed doses is where I kind of draw my comfort level, but I want to open that up to Hilary and Nick to chime in.
I agree with you totally, Karen.
Yeah, same.
Great, thank you. I want to move on to a question about syphilis for Dr. Van Wagoner. Does having a negative serologic screening for syphilis rule out odic syphilis? So in other words, if someone presents with an acute hearing loss but has negative non-treponemal and treponemal syphilis testing, can one then rule that out as an etiology?
Yeah, I think it's a really good question. And I think for the most part, the answer is yes. I will never say never with anything. I think that there is always a possibility, but that is the test that we would use to look. And if the RPR is negative, then I think that we can make the decision that it is likely not or is not caused by syphilis. Karen, Hilary, anything to add?
I think I would agree. I think I think it would be very rare. I think if you had somebody that you knew was very high risk or was exposed to someone with active syphilis, that might change your equation. But yeah.
Yeah, that's a great point. And I think that comes back to the importance of always gathering a history, and understanding who our patients are. I know in, the hospital system where I work, if somebody comes in with certain symptoms, they're going to get an RPR, or another test if we're using the reverse sequence. But really, it's not just the diagnostic test, it's understanding the context of the test in order to interpret and take care of the patient. So thank you, Karen, for that information.
Great. Next, I want to jump to Dr. Reno, and this came up when you were speaking about HPV. It's a question about HPV in men. So, really there's no way to screen for men. And the question is, what's the best recommendation for men who call in or come into clinic requesting screening for this? I think that's something a lot of us have been in that situation. How do you handle that?
Yeah, absolutely. And do know there are unapproved tests that sometimes people get a hold of for HPV screening, but those are unapproved and not closely examined. They're not FDA approved. We don't have really great data on them. And so they are not of any benefit. When I have patients who come in explaining that their partner with the cervix is undergoing management of abnormal pap smear, HPV, or perhaps even has anogenital warts, I do explain that we don't have screening tests. We do offer, and usually almost everyone accepts, a physical exam. And then, we talk about the potential longer term findings of HPV, and tell them that it's important to keep up with your usual health care, and that means having a primary care provider and access, if you are to see potentially a skin lesion that you're not sure that it wasn't from an injury or something like that, simply go to your primary care doctor and our provider and have an exam. I think that we also use it as an opportunity to encourage people to quit smoking, because there has been some indications from studies that smoking can contribute to HPV findings, meaning those with genital warts could have recurrences more often. And we know that smoking is a risk factor for infection with HPV. And we have had patients quit smoking just because they know that their HPV course could be altered by quitting smoking. So anything else, guys?
All right. We had a few questions come in around trichomoniasis, around partner treatment with trich. What's the recommendations for partner management so the partners of females that have tested positive for trichomonas, and then also alluding to EPT. So, that hasn't been part of the guidelines in the past, but I'm wondering if you could speak to that on how to manage those particular male or partners with penises that may have been exposed to trich.
I think the current guidelines recommend that active partners be treated. And so we certainly would go ahead and treat them. Unfortunately, there's not a ton of data like we have in women accumulating regarding multi-dose therapy, multi-day therapy compared to that single dose therapy. And so right now for men, they still are recommended to get that 2-gram dose of metronidazole. Thankfully, we now have tests that many labs have validated the use of Trichomonas nat in men in urine. So there is the capability to test men if there are persistent symptoms or issues with recurrence. But as far as, I think one of the things that can sometimes confuse providers is that for gonorrhea and chlamydia, we give this time span of 60 days. And in trichomonas, this is a notorious organism that can be causing infections for years and years. So knowing how far to go back in a client is not easy. And so typically we say their active partner, their most recent active partners, that we would go ahead and treat them. Am I missing a part of that question, Allison? EPT, as regards EPT, I think the data certainly is not as strong as what we have for gonorrhea and chlamydia as regards preventing reinfection and increasing treatment access to partners. But in the guidelines, that is a method that can be used to go ahead and get those clients treated if we see that there may be an obstacle to getting them in and assessed.
Okay, great. Thank you. So the next question is kind of a two-parter, addressing two different things. So one has to do with the doxycycline. So if you're treating presumptively for gonorrhea and chlamydia, and so you've given them both the shot and the 7-day doxy, but the chlamydia ends up being negative, should the patients continue taking the rest of the doxy? And then it's kind of the inverse of that question for PID. If everything's negative on PID, but you're treating them for PID, should they also stop the treatment or should they continue? So I know that's kind of two parts, but maybe first tackling if someone ends up not having chlamydia and you've given them doxy, what should the patient do? And that can be for anyone. Can tag team this one, it's two parts.
I can start and then hand it off. So I think if you're so was the first one if you had urethritis or cervicitis and a gonorrhea was positive, or?
So it was treating presumptively for GC, and I think you couldn't rule out CT. So you gave the patient the doxy as well.
Okay, if you have a NAT, then I definitely would stop the doxy, right? You're decreasing exposure to an antibiotic that a client doesn't need. For PID, it's important that you don't do that. And so it's important to realize that a negative gonorrhea and chlamydia in the setting of PID doesn't mean that you don't have upper tract disease and that you aren't treating other bacteria that may respond to doxycycline. So the treatment regimens that are approved for PID have proven themselves in that syndromic setting. And so it's not about tailoring it to something because you didn't find it necessarily. If you do find something, you certainly want to cover it. I want to hand that off to Hilary and Nick.
No, I actually, go ahead, Hilary, sorry.
I would say the only thing I would add is, because I agree with you, I do have them stop the doxy if the NAT is negative for chlamydia, but I do encourage them to throw away their unused antibiotics so that we don't see them deciding to take it at some point.
Yeah.
Yeah, that's exactly what I was going to add, is just because people put it on the shelf and then the next time it happens, they take it again and may not present, and there may be complications from that.
Great point.
Great, thank you. This is for, well, anyone, but it's about genital ulcer disease. It is a question, does PrEP have the same issue as HIV treatment in increasing the risk for genital ulcer disease in the first 6 months of treatment?
Yeah, that's a really, really good question. And so let me break it down into a couple of pieces. Really, the answer is no, that PrEP does not have that same impact. And the reason why is because in people who have HIV and they have advanced HIV, their immune system is diminished and they are immunocompromised. And what happens is when you start that antiretroviral therapy or the regimen to treat their HIV, their immune system reconstitutes. And it says it starts in that process can impact and lead not only to genital ulcers, which of course are caused by the virus, but inflammation that is caused by the body as it's trying to fight the infection. In people who are starting PrEP, I would anticipate that they are not immunosuppressed. And so their immune system is intact. And so we would not expect them to have an increase in the likelihood of genital ulcers in starting PrEP. What I would do is have a discussion with my patient if they have HSV and are starting PrEP about the potential benefits of starting suppressive therapy for HSV or for genital herpes, not only in reducing the likelihood of their outbreaks, but potentially reducing also shedding of the virus and transmission of the virus. So I hope that answers your question, but just to summarize, we do not see the same effect in people who are starting PrEP because they are not immunocompromised.
Great, thank you. Another participant had wanted to know more about the LGB molecular testing. They just state they weren't aware that that was readily available. And the question is, since we would be treating empirically and the results will not affect management, why would we test?
I think it's a great question. I would say that some folks, our own clinic uses this test a little more broadly than what we do for empiric therapy. And so if we have somebody who has symptomatic sort of severe proctitis, but even if it's not hemorrhagic and if they're not living with HIV and they're chlamydia gnats positive, we do the PCR just to make sure that we're giving them the optimal therapy. Now that's outside the guidelines. So it's something that some folks consider in their clinical practice. What I would say is having that result allows you to really provide that additional information to the client. And like I said, in our clinic, usually by the time that comes back, they're into that second week of the doxycycline. But as we talked about adherence is a big deal with 3 weeks of doxycycline. And if you can say to them, look, we proved it's LGV. LGV is sort of a bad actor. We really think this is your best way to clear this infection, make sure you don't have any sequela of lymphogranuloma venereum. We find that, that's important information to empower the patient and really help them motivate for that adherence to the doxycycline. In addition, in our setting, we also notify our state DIS, and they do reach out to partners and try to get them into treatment. So I think, if you don't have access, it's absolutely reasonable to be treating empirically and to be telling people with proctitis, if you have any recurrence of symptoms or failure to clear after your week, please come back and let us know and to entertain it then. But LGV is a pretty serious player. So it's serovariants L1 through 3. And it can be mistaken for inflammatory bowel disease. And so we absolutely have had patients come to our clinic who were recently diagnosed with Crohn's disease, who then sort of are feeling uncomfortable because they know they didn't provide maybe a full history to their GI doc or whatnot, and they're feeling a little uncertain about this diagnosis. And we check them and that is what they have. And it raises the whole question of whether they should be continuing treatment for Crohn's. And so being aware of this diagnosis is really important. As regards wide availability, it's a great question. So for us, our partnering reference lab does have access to it. And the way that we do it is we wait for a gnat. If the gnat is positive for chlamydia, our lab now holds all chlamydia gnats for about a week for us to say, hey, you know what? Can you send that on? And so we use that remnant sample. We don't collect more samples. We use that remnant sample and we get additional testing. Nick, Hilary, any other additional thoughts?
Okay, great. I'd like to switch back over to syphilis. There have been a couple of questions about doxycycline as an alternative treatment. Is doxycycline still considered an adequate alternative treatment for syphilis? And then kind of a follow-up is, do we know what the treatment efficacy is between the recommended, like say 2.4 million units of bicillin versus the 14 days of doxy for early syphilis? You're muted, Dr.
You would think I would learn, right? By this time of using Zoom. So it's a great question. And if you do look in the guidelines, there is a discussion of the use of both doxycycline as well as tetracycline as alternatives that may work in non-pregnant patients. Certainly doxycycline, 100 milligrams twice a day for 14 days. Is the length of the therapy, and it has been used for years and may be effective. The piece that I would say that is critically important is to follow your patients. So if you have to use an alternative regimen, following up when looking for a serologic response is really important. Now, one other thing I will say, this is related a little bit more to azithromycin, as you know, and as the guidelines discuss, it has been used in the past, but there is growing and has been macrolide resistance. And so that is not a recommended regimen. But yes, coming back, doxycycline can be used. I think what I would suggest is really digging into understanding whether or not the patient truly has an allergy to penicillin or not, to try to understand if we do need to go to an alternative. So Karen, Hilary, anything to add to that?
Okay. We've had a number of questions. This may have to do with more CDC partners, but folks are wondering when the CDC STI guidelines app will be released and other supporting documents. Erin, I'm not sure if you're still on, but do you have any timeline for us?
I wish I could give more specificity about when it's actually going to, the full app is going to be released. We do have an interim mobile site that's available. So the app is under development. It is coming. We anticipate it sometime this fall, but if I give a specific date, I'm just going to wind up being a liar. So I'd prefer not to do that. But the mobile site, if you go to the CDC STI treatment guidelines website, there are instructions for how to download the mobile site. You can download it to your either your Android or your iPhone home screen so that it opens directly from that page. And I see somebody just dropped a note about where you can find the directions in the class material. So I was just going to ask if we could include those instructions somewhere with the materials. So there is a kind of a step-by-step guide to show you how to do that. It's not quite as sophisticated, definitely not going to have all the bells and whistles that the full app will have, including a lot of images and integrated content that we have for other sections of treatment guidelines that CDC has available. So the full app will be definitely more advanced than what's out there right now. But I can say I have even personally used the interim app and it really does, or mobile site, and it does lay out the treatment recommendations for various pathogens and syndromes, and is really quite helpful in the meantime. So more to come. Sorry, I can't give a specific answer, but hopefully this is helpful until it's ready.
Great, thank you. We are at time. I just want to say thank you to our audience for the excellent questions. I know we didn't get to all of them. Please submit your questions to, I believe it's been dropped in the chat again, but it's STI-TX guidelines@cdc.gov to get those answered. And I just want to give a big thanks to all of our speakers today. Thank you so much. A reminder to our audience that there are going to be 3 more webinars that are going to cover the same information. So if you're looking for more or maybe missed part of today, please join us on September 14th, 15th, or the 22nd to review one more time. Thanks again. Have a good day, everyone.